Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome back to another episode of the EMS Lighthouse Project podcast, where we shine the bright light of science on the darkness of current EMS clinical practice. Now, this is a special episode. It's special because this is not just me recording a podcast. This is me sitting down in my hotel room in Ashland, Oregon, with some friends. And we were definitely talking about a paper, but the conversation kind of rambled around a little bit, as it does when you're sitting around with some friends. Now, the ramblings were almost entirely about science and about sepsis, and that is the reason I think it's a useful podcast. Now, I mentioned I was in Ashland, Oregon. I was up there for a conference. I was at the State of Jefferson EMS conference, and I was joined by some friends. Doctors Ed Racht, Ritu Sahni, and Maia Dorsett. And I talked to them. We had a couple of debates. I got to call Ritu an ignorant slut, which is always the high point of my day. And we said, hey, have you read this paper about, sepsis? And it turns out they had. I said, hey, let's get together before our dinner reservations and let's knock this podcast out. So they agreed. It's fascinating because the last time I was at that conference, I was also on a podcast with Ritu and Mikey and Ed, and it was fascinating because Ed gifted us with large amounts of toilet paper. You'll just have to go back and find that episode. A lot of fun. There was some rambling in this podcast, but for the most part, I left it in. And one of the reasons I did is I had to get up and take a medical control call, and while I was gone, Ed and Ritu embarrassed the hell out of Maia by telling her some objective truths, which was what a rock star she was. I had to leave that in because it's absolutely true. Guys, with that rambling introduction, let's get on to the Rambling Podcast. I hope you enjoy.
What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Not making much. Howdy, y'all. I am Dr. Jeff Jarvis.
I think I need to just introduce all of you.
I think this is a great plan.
We would get there faster.
Go for it.
It would be more accurate.
Help us out, Maya.
Ladies and gentlemen, Dr. Dorsett.
Yes.
Ladies and gentlemen.
So, hi all, or howdy y'all.
Howdy y'all, there you
Since
go.
this needs to be done right, we're going to have the woman do it. We are here on this special episode of the EMS Lighthouse podcast and a crossover episode with the EMS Show.
Correct.
So the combined title would be the EMS Lighthouse
Crossover.
Show.
That sounds
EMS
good.
Lighthouse Show.
I like
That's it.
So
We have some guests.
we have some guests.
We have Ed Rock.
It's a pleasure to be
of
here.
Austin, Texas.
Formerly of still lives.
still lives in
Still lives in
Texas.
Austin, Texas. Yep. You are the CMO for GMR, not to be confused with a system normally known as, or formerly known as AMR. Now,
Still
G.
AMR. So
Still
AMR is mainly the ground operations within the GMR umbrella.
Ah, very good. So
I heard
GMR
it's a small company
is
that
AMR.
ambulance work.
And
See, we are so screwed here. So GMR is AMR plus like reach and
Plus the flight side.
Aerobac and Rural Metro and Guardian Flight and all of our air, all our ground, all our FEMA stuff.
Very
Do you
good.
also have do you also have a couple of fire departments?
We have a lot of fire departments, so
right.
all of rural metro fire. So
Got
there's specialty fire, which are like airports and things that have chemicals and bubbling goo and things
boom.
that require a lot of reference materials on the spot, and community-based fire.
MSDS sheets.
MSDS.
Lots of MSDS sheets.
Lots of
So
MSDS.
is those famous boys from Texas, ZZ Top, say you're bad, you're nationwide.
We just say it's earth, wind, and fire that we have.
Fair enough. Fair enough. Ritu. My good friend Ritu Sahni from the EMS Show is joining us once again. This is the part where you just be quiet. Maia.
Oh.
Maia is the medical director for Prodigy, and she is also a recent guest on Ginger's Medic Mindset podcast. I just really want to call out what an amazing episode y'all had where you were talking about giving death notifications. Really, really good. Which actually also ties into a lecture we had, Dan Lemer, here at State of Jefferson, which is why we're here. We're all in a hotel room here in Ashland, Oregon.
Yes.
Beautiful, even if it is snowing. It's great. White stuff coming out of the sky as a Texan, not real clear.
Snow is beautiful.
Snow is beautiful.
You don't have to say beautiful even though it's snowing.
I'm with you, Jeff.
Snow is in fact beautiful.
Look, Jeff and I are used to all 4 seasons.
Yes.
Brown, tan, brown. It's a beautiful, right? Sand, dry, drier, not moist.
East Texas
I can't say moist.
has grain. So we are here with this joint podcast that I swear to God we've been recording for an hour and a half, and now we remember to hit the record button.
To hit the record button.
I might have done this in the past.
It's his first day.
So we're going to talk about a paper.
Maya, do they have the same shirt
nice
on?
They do have the same
Are they
shirt
pajama
on.
tops or shirts? Just real quick.
They're not pajama tops.
It's a pajama pattern.
It is a pajama
It is not a
pattern.
pajama pattern.
No,
Yeah,
honestly,
totally.
they are.
Really, Ed? Have you seen what you're wearing?
Right, exactly. And it shows up well on camera.
Oh my God.
Right. Get the Zofran out, baby, because this
Exactly. It's going to be, so this is clearly not your normal Lighthouse project.
It turns out that algorithms picked the same shirt for us.
They did.
which is really scary.
We both have the same personalized Stitch Fix stylist.
Personalized.
Yeah. I don't know if y'all can tell. I mean, this is a nice camera. It's pretty good resolution, but we're not actually the same person.
Correct.
Yeah.
I have hair.
What?
That's about the only
You
difference.
didn't want to show us your mane of chest hair?
No,
there?
we did that earlier today.
Yeah.
so
Ritu's
disturbing.
time to
Pass
EKG
the
would
rest
be
of that
longer.
Zofran.
Yes, it would
Really?
be. It definitely would be.
How about we talk
Let's
about
do that.
sepsis? Shall we?
Let's do that.
I think we
Sepsis.
need to talk about
I did a
sepsis.
lecture about that at this conference yesterday.
What was your lecture about? Was it about the Clovers trial, perhaps?
I included the Clovers trial in the discussion,
I think we should talk about the
but
Clovers
it was specific. It was a discussion about EMS approach to sepsis and kind of the role that EMS can play in sepsis. And I've heard Ed talk about sepsis a lot in the last few years, but just the idea that one, resuscitation starts when we take care of the patient. 2, early recognition of sepsis plays a big role, but also calling into question some of the things like overflow, 30 mLs per kilogram, being over aggressive. And also I think, when you look at the backbone of our current sepsis bundle, it's really based on the Henry Ford study, Manny Rivers study.
Manny Rivers. Early goal-directed therapy.
Early goal-directed therapy. It's even still called early goal-directed therapy. And pointing out that when you have a bundled approach, sometimes it's hard to pick out which pieces of the bundle or which not. What I think we learned from that bundled approach is that a protocolized approach to critical illness is important and helpful, but it's still reasonable to call out whether pieces of the bundle are helpful or not. And it's funny because when I think of the bundle approach in EMS that has been, in my mind, I'm going to say something nice about you, so just be quiet.
Don't hold this against him, please.
Okay, but
Cover your ears.
but we were here at this conference when I told
Not
you
in this hotel room.
No.
we were here at
was
this
a
conference when
different
I
hotel
told
room.
you that your paper about DSI was
yes.
selected as an LSA
Yes.
article because I was the LSA
Yes.
editor at the time for EMS. But that's a great example of a bundled
Yes.
approach to care making an impact. And it's sometimes hard to take out which pieces of the bundle are important. And I think one of the things you really learn is that a protocolized, thoughtful approach to care is better than no care.
You know, it's interesting when we talk about bundles because Manny Rivers' paper was all about a very specific bundle. And so there were lots of components to that. I went through medical school. I graduated in 2005, did residency from '05 to '08. I think I'm the young one here in terms of my medical practice. When did you go? When? We know they're old.
I graduated
What did they say?
an MD PhD in 2012.
In 2012, okay.
He's
And
the
did
same age
residency.
as me.
And,
I love it when
her
he
mom
calls
and
me
dad
old.
drove her here.
Okay, all right, well.
I spoke
I know that I
when
went
she
through
was a fellow.
residency. I think Manny Rivers, I think that paper, Early Goal-Directed Therapy, came out in 2001.
2001.
I remember hearing about
Small
it in medical
regional
school.
journal, the New England Journal.
And by the time I hit residency, we were absolutely obsessed about applying exactly that bundle. And there were lots of things in the bundle, but one of the things was central venous lines. We put central lines in everybody. We measured central venous pressure,
Yep.
CVPs. We measured oxygen saturations and venous saturations. But the key to this was early antibiotics.
And central venous
Early
separations, too,
recognitions, which is what I was trying to get out.
Yeah.
It's been a while since I've done that bundle. And we pounded people with fluids. As a matter of fact, this was one of the things I was very worried about. You would have patients with a history of congestive heart failure. I mean, I'm slightly exaggerating, but their EF is 2. And they come in with sepsis.
4.
And we pound them with fluids. And I remember very clearly saying, look, I think this patient with this horrible congestive heart failure, I think I'm going to really do harm by pounding with fluids. And the answer was intubate them and put them on positive pressure. We'll deal with it. They need the fluids.
Because what's going to get them first?
Exactly. Sepsis or the pulmonary edema. So that really brings up an interesting question, which is, which, as you were saying, we know that the bundle improved care, and it was a pretty good. And I don't remember what the mortality was, but it was like 10% increased.
No, it was better. So here's the thing. It was very interesting that this paper, which was well done, it's a prospective randomized controlled trial. But it was not blinded because it was hard to blind a therapy.
Right.
But it was a single center. It was only 260 patients. And I hate to say this as a Michigan person, but they didn't take good care of sepsis patients at that place. Fuck, that's probably terrible that I said that. But they had...
I will say that normal septic care, that paper, the control group did a much better job than your run-of-the-mill sepsis care.
But no, they had a 46% mortality in the control group.
Right, but it matters what the inclusion criteria are.
Sure. But that was a place that ran 50% mortality. And then when they went to the bundle, they cut mortality in half to the mid-20s. So like the number needed to treat is 5, 4 or 5.
And the interesting thing was, it was the entire bundle. So
Exactly.
Since then, we never knew what was the key driver of that mortality benefit. There were a lot of concerns about a very expensive proprietary product for measuring central venous pressure. We did some studies specifically on that. Turns out that's not it. Nobody's using that anymore. Then there was, they looked at, what was Don Yealy's paper where he took one piece of it out? Anyway, we've been looking at
There was
different
the blood
pieces.
transfusion piece that was part of the original bundle because of the theory of improved
because of the
oxygen
central venous
delivery.
oxygen. Yeah.
Yep, and that was taken out.
So the bottom line is we've gone after piece after piece after piece. And the paper we want to talk about today is one more piece of this puzzle. So this piece is about early fluid and aggressive fluid versus, and you could even say a liberal fluid policy versus a restrictive fluid policy.
It's not early and late, right?
No, this is true. It's true. Because
I don't want people getting the impression that this is like I go straight to
EMS.
pressors versus fluids, or this is EMS, right? These are patients who EMS is going to Right, EMS is going to deliver. And there is data, it's retrospective data, but there is retrospective data that in patients who have pre-hospital hypotension, fluids potentially have a mortality benefit. There's confounders there.
Sure.
But
And we'll hit this as I give a review of the trial.
yeah.
And our practice and regulatory entities and quality metrics and hospital-based metrics
Glad you, yes.
create an environment where very little deviation
Yes.
was tolerated. So this became, in most hospitals, an all or none event, even when clinicians felt very strongly that there may have been a better way to manage those patients. So it created a standard by which everyone was measured.
So I really want to talk about that.
Yeah, so CMS, who pays the hospitals, created a guideline,
a
metric that said that a hospital, as an example, if a patient had septic shock,
It was severe sepsis, right? So it didn't even have to be shock, which they defined as a lactate greater than 2.
Right. Which
hold on a second.
Which after I just did 15 minutes of yoga, and my lactate was greater than 2.
Yeah.
But
1.8, 1.9, 2, 2.3. Okay, there we are.
Audio podcast. This was Ed doing calisthenics and raising
lactic acidosis. There you go.
But the point is that if they were in severe sepsis, as Maya pointed out, you have to hit a milestone of 30 mLs per kilogram of crystalloid, and they didn't care what crystalloid it was, and that created a lot of issues, I think.
Yeah.
I think there are so many components, and if you missed any component, you essentially dropped out, right? So I ended up working at it became like a 1-star sepsis hospital, right? Because at an academic center, you never hit the 100 points
awesome.
that go along with it. Yeah, exactly.
Well, and it created the artificial. When was the potential for sepsis identified? So for clinicians, it was like as soon as you push that button, the stopwatch starts.
Yeah.
So did it actually delay care? I think in many circumstances it did.
Or, I mean, let's face it, the way to meet the bundle is, first off, you check in at triage.
Welcome to the emergency department.
I need some
hear
blood
you're here for
cultures.
medication refills.
Here's
Let's
your
go ahead and
antibiotic.
culture you up, right?
Bowl of Zithromax, right? Because it doesn't have to be the right antibiotic.
Right.
So there were a lot of bad.
We give a lot of 30 mLs per kilogram boluses to pharyngitis.
I think
that's
luckily the pharyngitis probably can take it, right?
Versus
the patients who come to sepsis. But I think there is a bigger lesson beyond talking about this for EMS, as we have started, right, developing through EMSCO other things. What are the national quality metrics, or what are the metrics that you're going to measure? I don't think, the concept of value-based healthcare as a reimbursement, as we move into being recognized as a healthcare profession rather than a transport profession, is things. And I think it goes into who defines what the metrics are. Part of the issue of those things that were defined is they weren't defined by the emergency physicians, right?
Yes.
Like they weren't defined.
Or our critical care colleagues who also have to deal with these patients.
Right.
Yeah, or our critical care colleagues. So the question is, when we are now moving into, I think that you can look at examples of where quality metrics gone wrong, and sort of think about how do we own the quality of our care and define the metrics by which we're measured, because there are. Right, like there was no balance. Right, we talk in quality. There was no balancing metrics of respiratory failure,
How many
pulmonary
people did we
edema
kill from that?
Yeah.
Yep.
Let's dive into the paper, because I think we've met the fuckery component.
So
of the
EMS show, right?
Yeah.
Bill, that's so.
And we're
I'm just saying
now.
that's a word from 50 Shades, so I'm glad you're like.
Oh, I've never read 50 Shades.
Neither have I.
Nor I. I believe there might be a. Right.
I'm just going to point out that I am pointing to Ed Rock's significant other, who just.
Wait, you read it? Yeah, good seeing you guys. Best of luck to everyone.
You're out.
I
think fuckery is a word that's been around before 50 Shades of Grey.
Oh, it's definitely been around,
I'm
but
just
definitely.
saying.
I'm just thinking if we were to look at the distribution of gender in readership of that book, it might be.
That's probably right.
I just misused the word gender, didn't I? Well, let's move on to this paper, shall we? The point I wanted to make is you really did, and I think you said that very well, that this sepsis bundle is a beautiful poster child for performance measures gone wrong. When you measure performance and you put massive, massive incentives, financial incentives, like we would like to keep the Medicare flowing and the doors to our hospital open, you better pick a measure that adequately reflects evidence-based care, and we just missed it on this one.
For individualized patients. So the bundle applied across the board with very little effort to try and sort out those subtleties where parts of the bundle could have been hazardous.
Absolutely.
Yeah, and I think, as sepsis is, I think one of the pieces about sepsis and its sort of our increased knowledge and awareness of sepsis, that's actually been a positive, right?
Yeah.
But all sepsis patients aren't the same. Yep. And what this bundle really did was just sort of built this idea that all sepsis patients, or in severe sepsis, not even septic shock, are the same.
Yep.
And they clearly are not. And it took the ability of the clinician, and frankly, I believe that the EMS clinician has the same sort of skill set, but it took that piece out. I believe that sort of benchmarks in care and protocolized care to some degree improves outcome, but I also think you have to...
As this did.
Yeah.
I think, and there is data that shows that the implementation of it did.
I think the key thing also there is I think there's so many things where, especially in retrospective studies, things like you can't separate clinical suspicion of the disease as an individual factor in getting sort of the correct diagnosis.
Oh, that's so good, yes.
And in a lot of these things, right, it's like a retrospective look, whereas we take care of patients prospectively. So actually one of the main reasons I got into EMS is before I did EMS, I actually wrote a grant. I was going to work on biomarkers and sepsis. My background is in genetics.
This would be the PhD part of your education.
Yes,
not the clinician part.
And but the reality is I was thinking about sort of how do we sort of detect who really has sepsis like down the line. But in the meantime, I was working in an emergency department where I couldn't get my patients antibiotics on time. And patients who had difficult access, like things. And then I rode in the back of an ambulance. I was like, they have 1-to-1 patient care time. Like, they can do all these.
But one's got to drive.
One's got to drive, right? But they can actually initiate these interventions in a time-critical way, right? The rate-limiting step for a lot of these patients was getting IV access, getting the initial fluid. So if I could shorten that time, and that's like one of the reasons I was like, well, I would like to improve sepsis care 10 to 15 years from now, but honestly, like I need to improve sepsis care like tomorrow in the emergency department because I have these really sick patients who aren't getting timely care. And I think the other big thing is, at the time, right, we were obsessed with lactates, but then Singer published all these studies on the use of capnography. And I work in a community hospital, and I don't have a lot of, it's crazy, but I don't have a lot of access to, I don't have capnography for every single... Sorry?
You're nailing your mic.
Okay. I don't have capnography for all things, but EMS
Notice
clinicians...
you can't stop the hand.
No. Just move it away from the mic. I'm good. There you go. So you have capnography. You may not have a rapid lactate.
So, exactly.
I'm hearing both, right?
But we found the data that basically...
No, the challenge... the challenge in a community hospital, like I work at a semi-tertiary community hospital. I have 40 beds. I only have 3 capnography bricks.
I have 3 capno bricks. They're in our defibrillators, which are life packs. That's it.
So I can't get capnography on everybody either.
Nasal capno is not part of sort of the routine diagnostic
But your
component.
point is that every ambulance
And by the way,
does.
This is such an important micro component of this discussion, which is our EMS practice of medicine, our folks in the field have the tools right there to make these decisions, almost all of them. Not everyone, obviously, but what a nice thing. We often think about, the emergency department's got everything, critical care's got everything.
Good God.
And in this circumstance, this is a really good example. It's
First
like in
step
the
is
olden days. Can we
clinical
borrow your
suspicion.
external pacer? Right? Remember that? The ED didn't have the
What do
external.
you mean? What do you mean?
Can you
Olden
bring your
days.
right?
I will say, if I want to know what the patient's entitled CO2 waveform looks like, I grab EMS.
Yeah.
Oh, absolutely. But I think the key thing is, I think one of the key components of the bundle that we know is important, like we don't need the study to show it's important, is thinking about the early recognition of the disease. And
Who is
That's
that? Is
you.
that me?
That's you.
Is that me? Oh, shit. I'll be right back. Talk amongst yourselves.
When he steps out, let's talk.
Hello, this is Dr. Jarvis.
So number one, he
Is your
he
mic
says
off?
he's younger than me,
Hey,
but he's
man.
younger
Is his
than me
mic
by
off?
like 3 months. What the fuck is that?
I just like to think that I would just like to make it. I graduated from EMS fellowship in 2017.
I know.
Gosh, I was
I'm not a baby because I was older.
No.
I was born in 2009, so that's
So, and I graduated from
Reborn?
EMS fellowship in
Reborn?
1998.
The family was saying.
But let me you graduated from fellowship 6 years ago, and the impact you have made in this profession.
I don't know about that.
I would agree.
No. I'm going to be nice to you.
I would agree.
The
I'm-
This is
impact,
awkward.
the
No, it
impact you have made in this profession as somebody who graduated 6 years ago has
And
been
continue to.
so incredibly outsized. Like, people ask me, who are your up and comers? I'm like, Maia Dorsett's a rock star. You are my first
Own it.
choice as a rock star in EMS.
Own it, be a woman.
So,
Own it.
no, appreciate it.
And it's, you know what it is? It's both the art and the science.
yeah.
It's the knowledge and it's the way you deliver it. It's your style, it's your professional approach, it's how you package the science and convey it and get it out there.
Oh, thank you.
Well, and it's also just clear that you really care. And you really care. And what's really important, I think all of us would agree, but I think you really do it really well, is you care about these people. And, you know, you and I have talked about this. You're like the mom of your EMS program, right?
Yeah, I love them.
You love them. But
There
that
you go.
comes across in everything you do. So, yeah,
does.
we're
He's
going to
right.
make you cry. But, no, I think I used to say you're an up and comer, but you've arrived. You're a huge impact with your work with Prodigy, with your
He's
work
not
with.
recording, right?
Yeah, no, he's totally recording. This is all
Okay.
recording.
Well, this can be deleted.
No.
No, it's got to
Your work
stay.
and your work with the registry and so no, I think
We
it's
even
great.
heard a while ago that you're considering doing some invention work, which is absolutely fascinating.
That's right.
Yeah,
Yeah, that's the women in EMS.
Yeah.
work.
That's right.
stay
So-
tuned.
But yeah, I mean, we can continue to have this conversation though about sepsis in this particular paper. But we did an aside to talk to you about your leadership and the
Well, I
impact
can
you've
say
made in
this
the
is-
profession.
So this was sort of the first, and it was other experiences in EMS that made me want to go into EMS, and things like being in patients' homes and sort of seeing people sort of counsel. But it was the frustration of the inability to provide one-to-one care in the emergency department to get things done in a time critical way. And so I returned. I had this small grant at the time, and then I had this sort of like, oh my God, everybody expects me to be a physician scientist. And I went to my program director, and I like told him I was having this like crisis of like who I was supposed to be. And he's like, what would you tell your kid? And I was like, oh, I would tell him to do what makes him happy. And he's like, I'm going to tell you the exactly same thing. So I returned that grant, but I tried actually to let me use this money that I had gotten to work on this other project to buy lactate meters. So I could do a pre-hospital, and they were like, it doesn't work that way. So I was like, well, here's your
But
money
what
back.
an excellent try, though.
I tried.
It was a good try.
I tried, and then
It's not an unusual Maya thing to try to finagle the system.
Oh, I finagle a lot.
to get a better outcome for our patients. So
The-
it's not an unusual thing.
And so we had collected all this data thinking about, pre-hospital sepsis screen and a lot of people working on it. And then it just so happened that the QSOFA paper came out. And so that's how I got interested in it. But after all that, I read the Singer paper, which looked at, right, that's Silvestri's system, all the brilliant things, but they said by introducing capnography, if we could learn and the sensitivity of using capnography, realize like I don't need a lactate. I already have the tool that tells me whether or not a patient is hypoperfused.
Yeah, I have, in one of my 2 counties, we use lactate, and then it's, you know, there are all the CLIA issues and stuff like that.
The data is so good.
We use the trainer, you know, the athletic trainer version, but I'm like, we should just probably stick with end-tidal CO2.
The Singer's paper basically showed that if your lactate was, your end-tidal was less than 25,
which is what
then your lactate is greater than 4, and then their paper on the sensitivity and the specificity of a screen, where they like plotted all the different, it's my favorite area under the curve graph ever. Right? They plotted all the different...
She's
geeking out.
AUC.
I just want to see that AUC. I just want to point out how nerdy it is that you have a favorite AUC curve ever.
It is
very nerdy.
I'll see your AUC and I'm going to raise you a Kaplan-Meier.
Yeah. But they have every vital sign. Every vital sign that you learn to look for sepsis.
How nerdy is it?
And then you look at CAPNO and it just kills it for every measure.
So here's a question. To that end,
I don't suppose the question is, when are we going to get to this paper? Are we?
Yeah. So we're diving in.
Okay,
we're getting there.
Our dinner reservation is in 15 minutes.
So this will work. This will work beautifully.
Okay.
The
Bring
battery,
it home. Bring it home.
So for another discussion, another day, because end-tidal CO2 in multi-system dysfunction is not the easiest thing to sort out in the back of an ambulance, right? It's not the easiest. If I give you a critically ill patient who's septic, hypovolemic, tachypnic, all sorts of things, and I give you an end-tidal CO2, do you know exactly what to do?
Somehow I'm not seeing how that's bringing it back to fluids versus pressors.
It's going there.
So,
is it going there in time for my battery not to die?
So what I'm going to say is that
it's more complex.
It's more complex than that.
It's also more... Go ahead.
But it's also... Every vital sign I take, right, I interpret in the context of my clinical differential diagnosis. And it gives you the ability to ask the question, I suspect that this patient is hypoperfused, right? And I have a differential for why they're hypoperfused, but it gives me information to say, corroborate information that yes, like there is probably a hypoperfusion problem. But you also, right, you take everything into account. You take the respiratory status into account, everything else. But to me, Singer's paper, even though it's an example of how a retrospective study that looked at protocol implementation of following, is a paper that totally changed, right, how I thought about the feasibility of screening for sepsis and identification of who is actually hypoperfused, and was one more tool that convinced me, right, EMS has this critical role to play, because those questions that paramedics or EMTs, if you have capnography at that scope of practice.
Which we do in Oregon.
Which you do in Oregon. New York
And
is
Texas.
getting there. Texas.
And in Texas, we can do a heart transplant if necessary.
It's a delegated practice state.
I mean, if
is
you've
my-
got
we
a
got
donor-
it in where it's
I don't even have
required.
to say it anymore.
Texas
Right.
is a delegated
Drink
practice
up, Jay-Z.
state.
But it gives you sort of more things like the paramedics can identify who is sick and who needs time-critical intervention and initiate it. And so we're going to talk about fluids and the reality. We've got there. Yeah. I think we can get there
And this
now.
is a
because
perfect segue.
I think this is a segue to
Unlike
talk
yours.
about
Because
fluids.
Because we got
and
like 3
pressors
minutes left.
And how we think about that. But the key thing is, I know recognition matters.
Yeah.
I don't need to take
Yes.
that part of the bundle out.
which may indeed be one of the
what we
most
talked about.
important
Yeah.
parts of the bundle in the very first place.
I agree.
Yes.
I agree.
But then the
100%.
question is,
See, this is why
earlier
I invite
fluid
smart people
or
into my
later
hotel
fluid?
room.
I mean, that's the question we have.
so how much?
Thank you.
Earlier
Like,
fluid,
and do you do early
and-
pressors?
or do you delay
later pressors?
later, not delayed, later
if,
pressors.
If I could pick a 4-leaf clover,
Could
and
we?
be lucky enough
If you
to
could
get the
pick
answer.
4-leaf
That's good, 'cause St. Patty's
clovers.
Day is coming up.
That's right.
Right, it's a St. Patty's Day.
You got like
Patty's Day.
3 minutes to run through this. Paper.
Yes. Here's the citation on the paper. This is
EMS
the
Show,
two authors, Shapiro and Ivor. The title: Early Restrictive or Liberal Fluid Management for Sepsis-Induced Hypotension. This was published New England Journal of Medicine 2023. This is actually a 2023 paper. Let me give you a quick rundown of
3
the
weeks
PICO
ago.
question.
3 weeks
The
ago.
population we're dealing with here is adults with sepsis and refractory hypotension. So that is hypotension here, systolic, less than 100, and this is refractory to at least 2 liters of fluid. So before patients are ever randomized, they had 2 liters of fluid, including pre-hospital fluids.
Right.
This was a multi-center study, at least 60 centers, overwhelming majority of emergency departments. This is a us sort of issue. So they included these folks refractory hypotension after the 2
And
liters.
hypotension systolic less than 100.
100, correct.
Yeah.
And they randomized them at that point after they had had 2 liters and were still hypotensive at 100. They randomized to either a restrictive fluid process for the next 24 hours with early pressors or a liberal fluid policy where they continued to give them fluids and would do breakthrough pressors only if needed. Something much more similar to the early goal-directed therapy.
Correct.
Their primary outcome, all-cause mortality. Now, one of the things that was interesting about this is that their protocols allowed them to give pressors through peripheral venous access.
Yep.
It did not require central venous access, which is one of my main takeaways from this paper. Let's hit the results really quick. There were 1,563 patients enrolled, 782 in restrictive, 781 in the liberal. So when we talk about restrictive fluids, how much fluids did they actually get? Again, remember this is after the initial 2 liters. The restricted fluids, folks, got 500 milliliters. Liberal fluid got 2.3 liters. So an additional 2.3 liters. We're just pounding the
And
fluids.
was there, I read the paper, but I can't remember, was there a difference what the crystalloid was? I believe it was either, it could be saline.
It was dealer's choice.
Yeah.
The majority was lactated ringers, but
It's
that
almost
was not
a pragmatic
controlled.
trial in that way.
Yeah, for that
Yeah.
part it really is.
Yeah.
They also looked at vasopressor use within the first 24 hours, almost exclusively norepinephrine here. 59% of the folks in the restrictive group had pressors versus 37 in the liberal group.
Well, it makes
and
sense because they were
right,
getting
early
pressors earlier.
And time to first pressors, they started in at 1.8 hours median in the restrictive group versus 3.2 in the liberal group. Okay, so bottom line here, so we don't belabor this, death before discharge, this is all-cause mortality before discharge, censored at 90 days, meaning we quit looking at 90 days. 14% in the restrictive group versus 14.9 in the liberal group. Overall difference, negative 0.9, meaning favoring the restrictive group, but the confidence interval went anywhere from negative 4.4% up to 2.6%. That is about as no differency as you can
It
get.
was stopped
No
early for
differency.
futility.
And here is the thing that was important for me. The whole reason we say we need central lines, because we've gotten rid of the central venous pressure measurement, is that, well, these pressors, these vasoactive drugs, cause your body to spontaneously combust if it extravasates horribly bad, and it's going to happen all the time with these peripheral lines.
Spontaneous
And
human
it
combustion
did.
is not
Correct.
a good goal.
Oh, it's ugly.
No, and that's what happens.
Think of all the drummers that it's affected in Spinal Tap.
It is true. So what we need to do is turn these central lines up to 11. So it turns out there was some extravasation in the 500 patients who had pressors through a peripheral line. 3. That is 0.6. 3 of them had extravasation within 72 hours. You know what we did for it? Nothing. Resolved
Not
just
even a warm
care.
compress?
Local care.
Maybe.
Okay.
Maybe.
All right.
So
Symptomatic.
here is my takeaway on this paper. So there are clearly some limitations, but overall, large sample size, randomized controlled trial. It was unblinded because it's kind of hard to tell whether you're hard to be blinded on this,
On the fluid amount, yeah.
but no difference. And I think what this says is that one more strike
Either way.
against just blindly following an algorithm and the need to use your clinical judgment to decide which patients benefit, which don't. And then the key thing for me, stop putting in central lines just because of this
Yeah,
measure.
that's-
Yeah, I
As a
haven't put
community
a
ER
central
doc,
line
this is a big deal for me.
in for anything other than patients who need like a lot of things, who have bad access.
Yeah.
So a lot less.
Don't do it for potassium. Don't do it for fluids.
I think that there's a few other points that are pretty interesting in this paper. So one of the biggest barriers in, for example, if I say, hey, I gave this lady 2 liters of fluid, I started on pressors, and I call the ICU and ask them to admit, their answer is like, maybe you can give them another liter, and then they don't need an ICU. And so there was...
Right. And we'll just keep this up until they're dead. And you know what happens when they're dead? They don't need an ICU.
They don't need an ICU bed. That's right.
So I think one of the interesting, there was decreased ICU utilization between the 2 groups. There wasn't, a big difference. So there's some things like maybe some patients can take a little extra fluids, and if I don't have an ICU bed availability, and sort of think about that, because there wasn't as much adverse events. But if you looked by pathology, like there's a table in there that has their baseline history. So patients who had a history of CHF, and it was a forest plot, so you're going to love it. I thought of you.
I will tell you
every time I see a forest plot, I think of Jeff Jarvis.
So here is the problem with the forest plot. It was really, really long, and it is so
And when
hard.
I think of really long, I don't think of you.
No.
And
So it is
we
hard
deteriorate again.
to cut that up and put it in a slide. But you're right.
But-
They did. They
so-
sliced, they diced,
and
they
I
did
think
lots of things.
To me, when I looked at that, because the guidance is right, we were talking about the role for like individualized medicine, and there was some things where they had the history
Yeah.
of it was so long it didn't fit even on a single page.
Right?
So they had things like
Familiar.
QSOFA
Come on,
score,
New England
but
Journal.
there was, I'm trying to find it. So history of chronic heart failure and end-stage renal disease. And when you look at, right, the patients with renal disease, yes, there's a little, tinkle
Confidence
of a little
intervals.
finger that goes across.
In other words,
the
not
line.
statistically significant.
Not statistically significant, but there was definitely a trend, and that makes sense.
Don't you feel a little dirty just talking about trends when it's not statistically
Yeah, I
significant?
know. Rumley Crow is judging me right
She
now. But,
Actually,
She's
Remley quit
keeping
listening
score.
a long time ago.
At least you're not talking about tacos. Then she gets very judgy.
but,
Or
but I-
starfish.
But I think that there's things to look at there and say, when I look at subgroups that make sense, like, do I have any guidance about who might benefit versus
Yeah.
another?
I think what's been interesting on this paper for me is I've read multiple sort of commentaries on this, and there's like a pro fluid group and there's like a pro pressor group, and they both jumped on this paper to say, see, we're right.
Exactly.
And to me, what this,
Or you're not wrong.
right.
Yep.
So what has I think this again sort of builds on exactly what Maia just said, this concept of individualized care, that all shock is not the same shock. Some shock is fluid responsive, some is not. And there is a component of clinician judgment that drives whether you go to pressors or go to fluids. If you look at these 2 big bins of 1,300, it was 1,600 patients, right? 800
Yeah.
1563,
it was like
780,
780 in each. When you look at these big bins, they're relatively equal, but it's very hard to get down to that individual level, and clinician judgment.
And
And
they
practically
excluded
speaking,
some of
There
the groups, right?
definitely
They excluded people who I think for the most part were congestive heart failure, et cetera, things like that. So I think that the key thing is if there isn't a huge difference between the two, then you can't make it a quality metric
I
because there are
agree.
patients who are going to be harmed.
Preach.
I figured so.
and there's a powerful EMS message here. In the back of an ambulance with a relatively complex patient, the idea that fluid infusion or drug pressor administration are my options to start down that path of treatment. I may choose as a clinician or medical director or as a system to say, in this patient population, let's make some choices about, is fluid administration a more practical approach given where you are? It allows you to make a decision that you're not going to hurt someone by saying, you know what, pressors, I got one person in the back of this ambulance, we're going boom, 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 versus fluid. I can make a decision that has the same impact on a patient.
So I want to try to...
If applicable in the EMS
I
environment.
like this. So I want to try to wrap up with a couple of things. As I was listening before I was rudely interrupted by my cell phone, you were talking about end-tidal CO2 and interpreting it in the context of other pieces of clinical information. And what you're essentially saying is you're using these other pieces of clinical information to help you form, dare I say, a pretest probability. So you're using this Bayesian approach that the world is not black and white. It actually does come in shades of gray, just
There it is
for you,
again.
Heather. And you have to take the entire picture into consideration. So it's not a straightforward process. And I think the benefit of this paper, other than no more central lines unless we really need them for something else, not just because we're running pressors, is that not all patients are the same. We have to use our clinical judgment to form a pretest probability, then look at how this protocol works. Guys, thank y'all
Once
very
again,
much. Once again,
a patient care guideline
a
will always
patient
beat a protocol.
care guideline. You know, I really want to talk about clinical decision support, but I'm not going to do it.
At a different time.
At a different time, because I'm going to exercise some restraint here. Now that we're 43 minutes into the podcast, now I'm going to exercise
There's
restraint.
going to be editing, though, right?
You would be surprised how little editing there will be.
There's a whole part that we made her embarrassed.
You
that
need to cut
No,
it out.
no,
No,
it's
Was this
staying.
while I was on the phone?
You need to
It's
keep
staying.
that.
It's
out.
staying.
Awesome. Okay, it
It's
sounds
not
like the
staying.
vote says.
No.
So, as
Women
long as
get
it's not
3 to
going
1
to...
vote
See,
to make up for all the years we didn't
All
have
those in
one.
favor of keeping it, say aye.
I'm
3,
eyeing-
4,
I haven't even
4 to 1.
heard it.
4 to 1.
Yeah.
All right,
Heather,
it
you
stays.
traitor.
Go.
Yes, yes. The other woman in the room
Own it.
throw you under the bus.
Own it.
So, I think this has been a fascinating discussion, mostly EMS show, a little bit of EMS Lighthouse Project podcast.
And we miss Mikey
in here.
V. Just let him know.
We
miss
do
him.
miss Mikey. I miss you. Guys, let's wrap it up from Ashland, Oregon, and the State of Jefferson 2023 conference. Thanks a lot. Take care, y'all.
Good night.
Thank y'all.
Just let him fucking talk, Ritu.
In this county, and then this is the 10th conference, but we haven't had one since 2019 because of.
This is awesome. By the way, here's an important technical note. You
Oh,
need to write
fuck.
this down.
Okay.
Because James probably doesn't know
Hit
this.
record,
But it
before
is
you-
important when you hit record on the camera to hit record on the audio.
on the audio.
Yeah.
All right.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the